Once again, Lisa and Kate, thank you very much for your perspectives and your personal stories. They're extremely helpful. We have about 30 minutes for questions from the roundtable. Before we do that, let me just ask both Lisa and Kate, and then I'll open it up to the roundtable. If each of you had a magic wand, and you could make some changes in some of the stories that you told, what would you do? What would you change to address the kind of situations that you have experienced? What would that magic wand do to change some of the experiences that you had? Lisa, would you like to start?
Sure. Thank you. A magic wand to change some of my experiences. I think definitely it would have to be some kind of something that would allow the communication to flow freely. Maybe an interpretation book. When you go to another country, you have this book that shows you what they're saying, and then you can understand. Maybe one of those kind of books.
Good. Very helpful. Kate, briefly.
Well, I would advise you to look at some of these videos, because that was close to the question we asked at the end, and we always ask is, if you had not a magic wand, but if you could talk to a group of health providers or whatever group we're asking about, what would you want to share with them? What would you like them to change? And basically, there's a lot of things listed, but communication skills, and I mean basic communication skills. Also training on what mental illness, the various mental illnesses, but beyond that, what are the ways to communicate with someone who is having a particular behavioral health issue? It could be cognitive, it could be affect, but learning enough to know not just basic communication skills, which I'm sorry, there's a lot of issues out there in the health community, but also specific to communicating with someone with a behavioral health issue. And the way you communicate, as Lisa said, will vary. So communication skills and more knowledge about behavioral health, so you can treat your patient as a whole.
Thank you. So let's take questions from the audience, from the roundtable first.
They can't hear you on the website.
Let's take questions from the roundtable first. What I'd ask you to do is first identify yourself to the microphone, since that's what I have to do here. And secondly, just put your little nameplate up this way so I can identify you, okay? So we'll take questions from the roundtable. Katina?
I want to thank you both for being here. We do these sessions a couple times a year, 3 times a year, and the best days are always the days that start with people really grounding us in lived experiences and in people's sort of life. So it's so brave to get up and tell your story, and particularly a story like the ones you all are telling that are hard to tell. So I particularly want to thank you for doing it, and make sure you know how much it matters to everything that happens behind these first talks. Just being grounded and connected is important. And I didn't say I'm Katina O'Leary from Health Literacy Media in St. Louis. I'm sorry. But my real question, and I'll ask you both, but it's a little bit of a different slant. But, Lisa, you talk a lot about experiences that would keep many people from going back. Mm-hmm. And you talked about very clearly that, people did things that caused trauma. I think that, as Kate described, that caused trauma that made your treatment and your experience much harder. And I would just love to hear if you have any thoughts that you feel like sharing with us about how you were able to sort of be brave and go back and keep going back after the trauma, and sort of keep going on. And then Kate, as a family member, I imagine that you have some of the same experiences. And so what keeps you going back and sticking to finding the right provider and moving on when sometimes maybe it looks like there's not that possibility in the world when you keep having bad experiences.
Well, thank you. Sorry. That's okay. Why I keep going back is I need help. And it's a help that I can't give myself unless I went back and got my doctor's degree. So I keep going back and I keep hoping. And I've actually been rewarded. My persistence has been rewarded with a couple of doctors, including Dr. D, who I spoke about, who are amazing. They're amazing. And I can get the help that I need there. And they're out there, and just have to keep looking for them.
So just in this room, one of the things that we can say to all the people on the call and the webinar is you can be that doctor that is the hope for people, right? Because there are a lot of providers in the room, and that experience really can change somebody's whole life in that experience. Yes. And it's brave to go back and keep going back and be persistent. But, you know, on the other half of that equation, somebody can do something to help it along, which is cool.
Yeah, and it doesn't take a whole lot. It really takes seeing the person for who they are, because everybody's so different, and just listening and making that connection.
Larry?
Kate was going to respond.
Kate?
I was just going to say that that wonderful psychiatrist who was stuck with my sister for many, many years has decided to retire. And he called me to let me know a year before. And I will promise you that the family's really a little freaked out about the fact that now he was our anchor. He was the one who made sure that if he saw something physically wrong with my sister, that something would happen in his system. But so we're very concerned, and I'm a little tired, and I'm also getting older, and I'm really concerned. I've trained my 3 sons. They've grown up with this, and I'm just hoping that between the 3 of them, someone's going to be in a state, find a way to be, none of them live in Maryland, find a way to advocate for my sister after I'm gone. But right now, yeah, the concept of having to find another psychiatrist who will go the extra mile is really concerning. I do know that there are a lot of really great primary care and psychiatrists out there. The question of how to find them is a little harder. And I was just yesterday at a 5-hour, an advisory group that's working on pediatric integration. And they were talking about the same thing, as what kind of information and education do we need to give people so that, and how do we find some tools to find those people? It's a quote, I'm sorry if I'm not allowed to say it, but it's a crapshoot. Thank you.
Larry?
Hi there. So, Dr. Larry Smith, I'm a primary care internist and currently the dean of a medical school. And I want to thank both of you, but Lisa especially, telling your personal story. It's just wonderful, and thanks for being here. I just want to give you an observation, having been a primary care physician, and so that you should know that psychiatrists are not interested in any information from the referring doctor, as well as the family members. Right. And that is a deep-seated cultural thing in that specialty of medicine. Mm-hmm. I often challenge my psychiatrists that they're the only physicians I ever deal with who don't want to be my consultant. They simply want to take care of the patient in a separate secret box, tell no one about what happens, for fear of the stigma, if it gets out, that that patient has a mental illness. That is a historic way that the profession grew up, and it's epitomized by the fact that if I go into my electronic medical record, besides getting a migraine headache, just because it's the electronic medical record, I can't find any record whatsoever of anything that ever happened in the Department of Psychiatry. It is hidden. It is electronically hidden from everyone. And that is true almost everywhere. And so until we're all willing to take a little bit of a risk that we believe that behavioral health has a biologic basis, and this is just another set of problems that we should not be afraid of telling people we're dealing with, we can't solve this problem. I asked our Department of Psychiatry to agree to allow at least the medications to be in the record, because it's dangerous to not know what medications a patient's on. And I was quoted New York State mental health laws that say that's illegal. I doubt that that's true. I've been told of lots of laws that don't exist. But I think a lot of what you both discussed is the real issue of we haven't even begun to say these are just another set of illnesses that we treat in patients. And we're never going to have an integrated team if one member of the team won't tell anybody else what they're doing. And so I think everybody should think about that. On the flip side of it, I understand that our society is not necessarily ready to just say this is just another illness. And there is a stigma. But, you know, in a micro fraction of time, we destigmatized HIV disease from a deathly secret to another illness. And I think we can face this challenge and do it.
Can I respond to that? So I was writing down, so I will be in contact with NAMI New York, I promise you, about, if you don't mind, or even if you do mind. We're an advocacy organization. I totally agree with you in terms of, you know, if there's not sharing of records, and sharing of records is hugely an issue. Now, I will tell you my own story of going to my primary care doctor and saying, I think there's something wrong with my Synthroid or thyroid medication. I seem to be having every month or every 2 months, you know, my mood changes, and this has happened before, and I'm really concerned. Can I please either can you change it or can you send me to an endocrinologist, because I don't have one anymore? And apparently and she asked me a bunch of questions, and one of them was, well, do you think you're depressed? What went into my electronic record was that that patient denies she has depression. So now my neurologist asks me about how my depression, et cetera. So that's a situation where the records are shared. I'm fascinated by the electronic records issue is huge. The stigma is huge, and I think the collaboration, not just between the different specialties, but with the patient and the family, is we've got a long way to go. But if you have a medical school and you're training people, we have some options of bringing some stories to help you frame it. Thank you.
And
Sorry,
as
I'm having.
sorry, as a patient with Dr. L that I had shared, I'd very much like those appointments shared with somebody. I need to still go back and see her. And the 2 appointments I've had, I would love to have somebody to talk to about how they've gone. And having it shared seems pretty good right now.
Michael?
My name is Michael McKee. I'm with the University of Michigan. So thank you for your talk. So I work closely with patients with various types of disabilities, and I'm also deaf myself. And so the burden of mental illness is really high among various types of disabilities. And so this is a problem we struggle mightily as well. So I wanted to just kind of follow up on the challenges of trying to find culturally competent providers also who have the ability to accommodate or maybe be accessible to these populations. And I agree that a lot of it has to go back to the training at medical school level just to even kind of develop those basic communication principles. I also just wanted to just maybe open up for you both again about the ability to identify and search these providers. Sometimes patients do a social media search on Facebook just asking, And I agree, it's a hit and miss, like crapshoot trying to identify these people. And many people struggle with closed panels, or their insurance and Medicaid is another burden as well. And we have that problem with patients with disabilities too. The other thing is really just trying to identify tools or resources, or maybe even develop these type of programs to help these patients find these providers. So I just wanted to kind of mention one. It was a small endeavor, but it was quite helpful for deaf signers. Is www.health.org. And they had a list of providers at the end. They, unfortunately, just because of time, they don't update it. Like, for example, I moved from Rochester to Michigan, and they still have my Rochester address as a provider there. But that kind of approach might be a good starting point. Even if the providers are full, they may have, hopefully, resources or other collaborators, colleagues that might be able to refer them to whoever they need to see. So it might be a good starting point. I'm hopeful for also the insurance companies to start identifying providers who may have skill sets or even languages in which they may be fluent. And I know some have looked at it and some unfortunately don't document it, but there is certainly a need to identify the languages they know, the skill sets they are able to care for. And this goes beyond just the specialty, but just primary care providers. Like you said, there are champions out there who, whether personal experiences or just have a niche or interest in working with these individuals. But the challenge is it's a very fragmented healthcare system, and trying to identify, this one person and many thousands of providers. So I just wanted to open it up, and thank you for taking the time to talk today. Appreciate it.
Right on. I think it's the fact that the disability community, and actually at least in Maryland, all the agencies that work on disabilities in general has all of a sudden, NAMI and other mental health or behavioral health organizations have started to be invited to the table. It's really surprising to me that it took this long for us to be able to get on a task force around disabilities and smoking cessation, or disabilities and physical health, or whatever. And I'm really pleased. I would love to see how we could do, some way that people can locate. The way we locate doctors is that we do not refer people from NAMI. Our people on our helpline are not allowed to give names of specific doctors. However, in our peer support groups, I promise you, people are sharing which are the doctors that they were working with that went well and which didn't. And there is sort of we have an emergency. I know the heads of the various systems, and I can make a phone call and say, we need somebody for this person. But yeah, it's haphazard. Thank you.
I can say for the autism community, it's kind of a grassroots effort where if somebody finds a good doctor, they would pass it on, maybe put a link on their website if they have one.
Yeah. Good.
Ernestine?
Your mic's not on.
Ernestine Willis at the Medical College of Wisconsin, pediatrician, and I do appreciate you sharing your personal stories when it comes to behavioral health and mental health issues. Lisa, I was just curious, as you talked about it, trauma and recurrent trauma is definitely seemed to be a part of your personal experience, but as you refer to your children, I was wondering, what has therapy or interventions been for the children, and have you found more successful providers for them, or some type of family therapy?
Well,
Comfortable with sharing?
sure. I have had my boys in a grief, it's a grief center for children, once a week, except for summers, since we moved to Maine 2 years ago. My husband has been gone for 3 years. So they also have supports at school, and they have also seen their own private therapist with good results. Mm-hmm.
Johanna?
Johanna Martinez at Northwell Health and Zucker School of Medicine. I'm a primary care physician, so thank you. Everything that you say hits home. Personally, I still do see patients 2 to 3 times a week. So my question is, I think, and I try to teach our learners that the patient's voice is the most important, in that I think in every other field outside of healthcare, the consumer has so much say on the product that is being delivered or how that product is being delivered, and yet in healthcare, we have a lot of room to grow in that area. So there are things that we're doing like Press Ganey surveys or patient satisfaction surveys or systems where we actually have patient advisory groups or patient and family advisory groups, but we fully understand that that is a dearth of really getting the patient voice. So I would love to hear from you guys, how do we as a healthcare system better operationalize, systematize how we get the patient voice, not in terms of their personal experience on their health experience, but on the process of how we deliver care.
Go ahead, I need
So there's a whole lot happening in that area, and the program that I've been working with for a SAMHSA-funded program for 7 years is working on pediatric integration of mental health and behavioral health, and specifically my role on that group is about family. It started as family engagement in the care, but it rapidly became, through our advocacy, a focus on not only that, but on patient and family involvement and engagement in system and program changes in design. And there's a lot out there. It's hard to even start with, but there are several articles already, and there's a toolkit through Hopkins Public Health, and if you want to have more information, I can get it to you. There's a lot of just very simple things that people can do to make, and the focus of that particular project is pediatric integration, but it's also around trauma and recognizing trauma in everything from trauma that's actually directly affected you from a traumatic event, as well as social determinants of health. I could just start spitting it out, but I take 10 minutes. Love to. There's some really good stuff happening. Sorry about that.
I guess if I understand your question, and from my own knowledge base, I can speak from as a parent. Just moms really do understand their children, and there's a high percentage of doctors that I've gone to for my children who don't think I know them at all, and I would just say listen to the moms. I mean, it's a great beginning.
And I'm going to jump back in and say, in terms of that is so important, and then on top of that, there are things like patient satisfaction surveys, sure, but what happens with them? Asking people, making the office itself trauma-informed and inviting for family engagement. It's about doing such things as following up with patients afterwards and asking if they would like to come to a focus group. We could go on and on and on, but yes, we know our children. We may not be able to communicate sometimes as well as, we don't have the vocabulary, but we also can really, really help you see what little things that are happening in the visit as well as the office and the follow-up that are trauma-inducing or just not as effective. We're really full of suggestions, I promise you. Thank you.
Chris?
Chris Desi, Bristol Myers Squibb. Thank you for your input. It helps us decide on where to focus our energies and what to deal with. I'll boil this down to, and I know the answer to this question, but the one thing I was going to say, the older I get, I'm really tired. As I age, I'm able to say we've been dealing with problems longer, right? We've been dealing with issues like this for decades, and we have to get to solutions. are there sufficient resources for access to psychotherapy, right? Communication involves at least two people to be able to speak. I was struck that there are communication problems still with mental health professionals, let alone folks in primary care who are left in the dark sometimes. That's all. I just wanted to get that on record. Are there sufficient resources for that kind of? And to add to that, could there be additional resources provided for primary care to address your comment? I took your comment about the extra mile. I think the extra mile should be what the expectations are in dealing with individuals like this. And as a clinician and transplant on the medical side, my most challenging patients were the ones with mental illness. So, okay, I left. Go ahead.
No. I mean, in Maryland, which you would think was pretty well supplied, access to psychiatric help is very difficult. There are large parts, just speaking of children, there are large parts of the state where there is no child and adolescent psychiatrist, period. But there is a program where there's called BHIP, where behavioral health child and adolescent psychiatrists who are researchers and other people who are in Baltimore or near DC who telemedicine, a primary care a pediatrician can call and get an instant response. But no, there's not enough access, and also what your insurance pays for and who's on the panel and whether they're really still taking patients. And the other thing is that psychiatrists, I'm not one, so this is not self-serving. Psychiatrists do not get paid remotely what most other specialist doctors get paid. So there's not as much incentive for people to go in to provide direct service. I could talk forever.
So before we end, Larry and Johanna and Ernestine, primary care is...
They can't hear you on the webcast.
Here.
Oh, you got mine. Okay.
Yeah.
Sorry.
I fooled you this time. So we've identified a problem in communication, obviously, with primary care, and whether it's with the psychiatry area or whether it's certainly with the patient. Part of it, I believe, is related to how healthcare delivery occurs in 2018 and 19 and 20, whether it's the payment issue, whether it's the time issue, whether it's the education prior to becoming a practicing physician. All of that needs to be addressed. Are we prepared to address it? Larry?
So obviously education has become my business, and I can tell you that we teach neurology and psychiatry as a single entity. We teach that all of this is basically a biologic disorder, some of which we understand completely and some of which we're only beginning to understand, but we make no distinction. Our students then go into a clinical world where they're stunned that no one thinks or behaves that way. And it is very difficult to sustain learning that is never reinforced in the actual care delivery space. And so it can't start in medical school. Right. It's got to start with the people that become their role models when they leave the cloister that is the first 2 years of medical school and go out into the real care world. And what they see is something totally different from what they're taught.
Yes, Arthur.
Behavioral health and mental health can't start it's a start, like Larry said, would be in the medical school. But I do think that destigmatization of mental health and behavioral health and what supports that exist throughout the community need to be paid attention to. And we're trying to look at some of that collectively in the Milwaukee area around what do we do in communities who have really been stigmatized by mental health, who don't trust the mental health systems to provide effective care. So I think it's a broader integration of how we look at behavioral health and mental health.
Johanna?
To the points that already have been made, I think that as educators, I think we are fully prepared. I think that things like in ACGME and the AAMC in terms of the regulatory bodies and what they're recommending for physicians in training to get have really acknowledged that social determinants of health and behavioral health are probably the biggest predictors of health outcomes, and that we really need to be teaching our any sort of healthcare force that if we want to save lives, we need to focus on that and not just the biological. But I think to Dr. Smith's point that if our system and our older generation physicians that did not get that same curriculum are not modeling, or there's not a system in place that can actually reinforce what they're being taught within 30 days of being in the actual setting, all those things go to waste.
So thank you. I think those are very good insights. And thank you once again for sharing, both Lisa and Kate. These are very emotional issues. They're very difficult to relate to others. We had a very good audience who was very interested to hear about what you had to say. And so thank you very much for sharing and being part of the meeting. Thank you.
Thank you.